Hi, welcome to Lean Blog Interviews. I'm your host, Mark Graven. Our guest today, he's a returning guest. He's Mike Eisenberg. He joined us in episode 329 back in 2019. We talked about his documentary titled To Err is Human. So I hope if you haven't seen that documentary, go find that online. There'll be links in the show notes. You can find his first episode at leanblog.org/329. Mike's been a filmmaker since 2010 with his production company called Tall Tale Productions after completing his BA in journalism at Marietta College in Ohio. And as we talked about last time, Mike's father was Dr. John Eisenberg. He was a leader in national patient safety efforts as an expert, I'm sure, as the director of the Agency for Healthcare Research and Quality, or AHRQ, until his passing in 2002. And Mike was kind enough to tell me about his new documentary released last September. I've been able to watch it. It's called The Pitch, Patient Safety's Next Generation. And I hope you'll go check it out and view it on streaming services. Again, there will be links in the show notes. So Mike, welcome back to the podcast. How are you?
Thank you. Good to be back. It's hard to believe there was anything that happened before that year that came after 2019.
Yeah.
But it feels like ages ago. A lot has happened, but it's good to be back. And I think it'd be good to talk about what has happened. I mean, the changes that we explored in the new film are kind of a testament to all that. So anyway, Thanks for having me. Excited to be back.
Yeah, it's good to have you back. And, there are certainly important topics to discuss today. I just want to touch briefly. I don't think I knew this last time I saw your bio on a speaker's website that you were drafted by the Cleveland Indians in the Major League Baseball draft. You played 3 seasons of professional baseball. So
there's a gap between when I started my college career and became a filmmaker. In the middle of that, I had a short stint in pro baseball, which of course, I've been trying to weasel into our projects for a long time. And I got to do a little bit of it on this new movie, but still had even more ideas of how to sort of connect the two worlds. Mm-hmm. And that was a big moment in my life and a really amazing experience. And every time I'm at a conference or healthcare event, there always does seem to be some Cleveland Guardians or Indians fan in the audience who comes up afterwards and says, "What? Can't believe you played baseball for them." So it was short-lived. I didn't make the majors, but I had a great time, learned a lot.
Yeah. Well, good. I'm glad you got to experience that. And I learned from your baseball reference page, I wouldn't know by looking at you through the Zoom window that you were listed as 6'7".
Yeah, I try to stay on the bottom part of the screen to avoid any sort of tells.
Left-handed or right-handed pitcher?
Right-handed.
Right-handed.
If I was lefty, maybe my film career would have started a little later. It's possible.
Being a lefty is a big advantage there for sure.
Yeah.
I've just got a baseball here that I use kind of like a fidget spinner while I'm on meetings or on calls. Not because I was a skilled pitcher. I did so in Little League, and that was it. But
I always have one nearby. Although now I have a toddler, so I have to keep them higher up.
Yeah. So be careful. So you as we were just getting started here, you mentioned, all the things that were happening, related to COVID and questions around what did that mean for the patient safety movement. December 2024 marks 25 years since that Institute of Medicine report, To Err is Human, was first published. I know you talked about this in the last episode, but it's been a while. I mean, if you could, kind of recap your father's role in that report and how you got exposed to it through his work.
Well, I know that my father was a significant role player at that time in the work being done around patient safety and, general research around quality improvement in healthcare. His career before that was, I think he had his foot in a lot of doors. And I'm not a historian on my father by any means, but I definitely understand more now than I did when I started these projects. And I think what it showed me when we began making To Err is Human was that if we're going to tell the story of patient safety and healthcare we should start where he finished.
Mm-hmm.
And we talked to a lot of people at AHRQ, the Agency for Healthcare Research and Quality, and talked about what was really important to him and what his career really focused on. And I think that gave us a really interesting insight into how to possibly tell the story differently, because it's been told the same way in many ways for those 20 years since the report had come out.
Yeah.
And he always was very much trying to push the story away from blame and shame and try and find a way to solve these problems by incentivizing people to do well, or by just sort of creating an emphasis on quality and improvement. And I know a lot of people still have come up to me today, even in relation to a screening of one of these films, or I'm speaking about these topics, and they knew of him. And it's always very rewarding. I mean, it's hard to believe when you're 17 years old that your dad has this much impact on so many people. And over the years since he had passed, I really learned a lot about it. And that's been the secret, treasure I've gotten from these films, and one of the reasons why I love to continue to pursue it. I'm fulfilling somewhat his legacy in a way. And I didn't intend to do that, but I find the topics interesting, regardless of him. I find the topics interesting, and I think it doesn't hurt to keep me grounded and not so easily distracted by some of the things that a lot of documentary filmmakers will be easily distracted by, right? The craziness, or the conspiracies, or the shock and awe of things that happen. That stuff needs to be shared with people, but really, how do we get down to improving the healthcare system? Yeah. And I've enjoyed diving into that as an outsider in many ways, and keeping a sort of eye on what my dad would want to see if he was alive today and watching a film like this.
Yeah. What are your views, either as an outsider or informed by a lot of the insiders that you talk to, about, it's hard to make generalizations, but the progress that's been made in the last 25 plus years since the publication of that report?
Well, there's two sides to the coin. Almost everybody I've spoken to is an optimist, but they won't ignore the fact that it's not anywhere near as far along as it should be. And there's nobody in healthcare, I don't think, that would realistically say that either. But at the same time, if you were to find somebody out there who says it's horrible, everybody's doing a terrible job, nobody wants healthcare to be safe because it's all a money game, I think they're also deeply misunderstanding what healthcare professionals are trying to do. Even CEOs, who are usually the target of the all this is all about money kind of conversation. But it's my job to ask questions and to be a proxy for the audience that doesn't already know all these things. And so I've been able to really sort of ask the questions to these people of, okay, if it is getting better, why am I not seeing that? And I think that's, again, also a twofold answer, where it's like, in some capacity, healthcare has a responsibility to make sure that the patients all feel safe and taken care of when they walk into a hospital. And yet at the same time, in 2025, we all expect a different level of transparency than we did in the late 90s from our healthcare system. And so that's where this has become a really interesting topic to explore. And the most important thing I bring up a lot is, when that report came out, those numbers were shocking. 45 to 95, or somewhere around there, 1,000 people dying every year from medical harm. Like so many healthcare issues, the data has accumulated over these 20 to 30 years, and people in healthcare understand way more now than they did then about what actually constitutes a medical error or an untoward event or something that should have not happened to a patient. And that's part of the reason why the numbers get so staggeringly high, but also why there's no consensus on the numbers. Right. It's an inexact science. But what we all agree on is that one is too many. And if a problem happens in healthcare that you can solve, we should solve it. And that's what brought me to the new film, which was, okay, we explored the topic of patient safety in the first film, and we explored about how people are doing the work to improve it. But now, looking forward, all these other industries are recognizing their flaws and incorporating technology to improve or close those gaps. Is healthcare doing that? And that was an interesting question to pursue as a full film and then follow up to Two Errors Human.
Yeah. Yeah. I mean, the numbers from that IOM report were estimates, looking at sets of charts and then having to extrapolate across a national population. So even within that range, it was like, a 2x range of it. It could be this number or it could be twice as high.
Yeah.
Different studies in more recent years sometimes throw out numbers that are yet again twice as high. I don't read that as saying somehow twice as many people are being harmed. I think it just goes to show when there's such a wide range of estimates, that we don't have real data, which is, I think is a matter of that transparency concern that you bring up. I hear people complain, well, the estimates are bad. I'm like, well, give us real data. We don't have to rely on chart reviews and estimates and extrapolation.
It's not a ones and zeros kind of problem either. Mm-hmm. There's a lot of nuance. And, even going back to our first film, we explored the story of this one family who had gone from tragedy to empowerment, where they're speaking about their experience and they're making sure that these problems don't happen at other hospitals, et cetera, and doing it through positivity. Watch the film, you'll see. But the reason I bring it up is, one person died, another person was diagnosed with cerebral palsy, right? The infant who got cerebral palsy is living with that for the rest of his life. Someday, hopefully in the distant, amazingly far away future, he'll die, but he won't probably be listed as a death due to medical error. Mm-hmm. But what we saw is his entire life has been changed. The course of his life was changed due to medical error, due to a $15 test that wasn't performed the way it should have been, and is now a standard everywhere. Mm-hmm. You can't calculate that.
Right. You
can't even calculate Pat Sheridan's death because he lost 6 months of treatment due to a misdiagnosis, which was a communication breakdown. Mm-hmm. That was a medical error. That was something that should never have happened.
Right.
He still had cancer. He still died of cancer. He was not a number in that 45 to 95 range or however, whatever one you want to look at.
Right.
So that's where it gets really tricky. Like who are we calculating as death due to medical error? And there's never going to be a consensus on it. And so that's why I think we have to move away from numbers. And it's good to show them to people to maybe get some attention and get people talking. But at the end of the day, that's all it does. It gets you one day of news headlines, maybe. And then people don't care anymore because it feels too big to do anything about it. Mm-hmm. But the real way to solve patient safety, at least what I've explored or believe in these last 10 plus years of diving into it, is you have to do it at the human level. You have to find out where are humans the most human in the healthcare setting, and how can we make it so that we don't have to rely on them being perfect all the time.
Right.
And that's when you see really good success stories. Mm-hmm. And that's where technology can step in a lot of the times too.
Yeah. And I think a lot of people listening, I think this audience would be biased toward agreeing with your statement and things that I would say and other guests would say. Blaming and shaming people is not the solution. People come to work wanting to do a good job, and there are systemic breakdowns. There are process problems. Those are the things that the human processes happen also at that human level, like how the work is done, what's getting in the way, how do we help protect not just the patient, but protect the humans working in these systems from protecting them from human error. Because we're all susceptible to it, especially when fatigue and distraction and other things creep into all of this. And I think one other thing we're going to add, or we can talk about a little more before getting into the new film more. You made this comment about, well, if we're making improvement, why am I not seeing it? And my observation anyway is that averages are deceiving. If we had good data and averages, that there are many organizations that have done that work, as you put it, at the human level, improving processes, communication, systems, handoffs. Some organizations have essentially eliminated hospital-acquired infections, and some organizations have not. And I struggle with being an optimist about, look at all the great things that are happening over here. and then getting
Yeah.
discouraged about, well, why is that not spreading? I'm curious your thoughts on any of
Well,
that.
I thought, it's early February 2025. There's a big elephant in the room right now, and that's the aviation industry. When we made Two Errors Human, we really focused on aviation because aviation has been for so long the standard bearer, the cream of the crop of high risk, high reliability industry, and being safe. Accidents happen, but they weren't really fatal events, not stateside. And now suddenly everyone's like, should I even get on my next flight? When, there are millions of flights a year and two things happened in completely different sides of the aviation industry even, and completely unrelated and coincidentally happening so close to each other. But the reason I bring this back up is when we were doing the film Two Errors Human, the parallel was how do you train doctors like you train pilots, and how do we make sure that they're prepared for everything, and using that as a parallel. But now it's sort of another interesting cookie jar to reach into, because like when you look at healthcare and you look at medical error, preventable harm in general, we don't really hear about it, unless you look for it. And if you are the kind of person who's looking for things that went wrong in the aviation industry, like near misses, for example, you'll find them. There's tons of them. Yeah. And they make it kind of easy to find if you want to, but nobody wants to hear about it because we want to believe that the aviation industry is as safe as it is. And it is safe. Just like healthcare is generally very safe and good and you get what you need. But when it doesn't happen, in healthcare, it's a very personal experience. It's one person at a time. And that person and their immediate family and their friends all find out about it, and they're horrified. With aviation, we all find out at once. We're all horrified. We demand answers.
Yeah.
And so I think what's interesting is two things happened in a very short span, and now everybody's freaked out about flying. In a week, they won't be. Yeah. And in healthcare, something happens to you or your friend or immediate family member, you kind of get nervous, but then you're like, that's not going to happen to me because it's their problem. Yeah. And so that's why we end up in this cycle where, I'm 2040, 2050, 2060. We're still going to be talking about patient harm. And so the question is, how can we make it a priority? How can we get the general public to a place where they care about this? Yeah. They expect it the way that the car industry expects it, right? I expect when I buy a car that safety is the thing that they're touting and proud of.
Yeah.
We don't do that in the healthcare system because, we don't want to.
Yeah. Yeah. I very rarely have I seen a billboard with a hospital advertising some sort of award related to patient safety. I have seen it, but I think, like they don't want to go there. I would argue there's more variation across healthcare, which I think people assume all hospitals are probably equally good. I think it's more fair to say all airlines, U.S. based airlines kind of under the same standards and regulations are probably equally safe and same, might be true with other countries. But I think part of why aviation is so safe comes back to the issue of near misses. Like occasionally you see reports like Austin, Texas, a city that I pay a lot of attention to. There were news reports that there were an unusually high number of near misses at the Austin Bergstrom Airport. And I think aviation does a better job of reacting to and learning from those near misses, which is why, we had gone, I think it's part of the reason why we had gone 16 years without a commercial aviation fatality in the United States. I think I wish healthcare would do a better job of that, because I've seen in instances large and small, they say, well, nobody got harmed, so okay, good. And they move on. And I think that kind of dooms us to future failure.
But at the end of the day, whether a person is alive or dead or injured or not in the healthcare system, I think the most valuable commodity in healthcare is trust over money. It translates to money, right? And if a patient, like for example, right, I live in Chicago. Chicago is well known for having a big, geographical demographic thing. And when we talk about healthcare in my city, if I have an emergency, I want to go to Northwestern. This is all personal preference. Like, it's just like, I want to go to Northwestern because I feel like that's the most well-organized, well-oiled machine. But I'm sorry, not an emergency. Like if I have a healthcare issue, a long-term issue, if it's an emergency, just take me to the closest place, please.
Sure.
Just get me there. I don't want to get stuck in 15 minutes of traffic just to go to Northwestern and possibly lose whatever, right? And that's the ignorance of healthcare and the health experience that most people have. I still have it, whether I'm making healthcare documentaries or not. Insurance plays a significant role in whether you pick a hospital or not. What ambulance picks you up plays a significant role in which hospital you end up at.
Right.
So it really does matter that all the healthcare systems, at least in each city, are on the same page. I think it's too much to ask for that a hospital in Boston and a hospital in the Panhandle of Oklahoma do the exact same thing, have the same tools.
Sure.
Because they shouldn't. They should have access to them. But the hospital in Oklahoma might not need some of the things that Boston Hospital needs.
Yeah.
But in Boston, if I'm going to be, if it's a multiple choice of 5 different hospitals I could end up at, I would like to know that they're all using the same tools to be safe and provide reliable care.
Yeah.
And I think that's a reasonable expectation.
Yeah. Yeah. I mean, I think every hospital can have equally good processes, even if they don't have access to the same technologies or some of the, really complex care. I'd like to think any hospital can address somebody with a virus and a high fever or a sprained ankle. I'd like to think any hospital with an MRI machine could have equally good processes and screening and communication to make sure that a patient or a staff member isn't harmed because they have metal on or in their body and get pulled into the MRI magnet. Things like that don't require great financial resources to help ensure that type of safety.
But also what's interesting is the technology itself that has made healthcare so advanced and modernized isn't made by the hospital, whether it's an EHR or whether it's an MRI. Like they're made by big corporations who make the thing. And in the end, they do care because they want to keep selling that thing. It needs to work, and it needs to work right, and it needs to work all the time. And where the hospitals end up, I think, having their own responsibility is in a lot of those things that are less obvious. Communication breakdowns. How does the system run? How do they manage when it's overloaded and when they're understaffed and all those things? And that's where the rubber meets the road with patient safety. That's culture of patient safety. There's always going to be multiple things for a hospital to choose from, except for the AHRs, which there's 2, but I'm sure they have multiple companies vying for them to use their equipment. So at the end of the day, all that equipment's probably fairly similar, or at least should be. And how the people are trained to use that, how they're trained to understand when something's not working properly, that's where a hospital's culture really comes into play. And that's where I think you can't ignore it. And those are the things that should really be standardized across healthcare. But who's going to do that? Who's going to standardize that?
Yeah.
And it's really a tall ask to put that on government. I mean, that's not going to be a viable relationship. So I don't know the answer. And I think that's why I'm still making movies about this and could be for decades longer. But I do hope that people understand that when things go wrong, that's because something went wrong between, the hospital staff or the experienced people who are there trying to do good, just like probably made a very simple mistake that got catapulted into a bunch of different things.
Yeah.
But when you drive a car and like the brakes go out, then you get a recall and every car that was made in that one factory comes back.
Right.
Right. So,
yeah. And one other thing to touch on before we dive in and talk about your new film, you bring up Aviation, and I think about the blame game. If let's say first off, if there's an accident and I think there's there's human nature, a societal impulse to say, well, who screwed up? The driver screwed up. And like, well, then you've learned, well, there was a mechanical systems failure, not the driver's fault. The driver was a victim of that as well. The same could be true in healthcare. You could have all these different factors, and sometimes it comes down to equipment design. Anesthesia has gotten really good over past decades of sort of standardizing and forcing out opportunities for confusion about how, at a high level, different knobs work, and that turning a knob clockwise on one type of machine does the same thing as all the other brands, where it used to be on a certain other type of machine you had to turn it counterclockwise. And like we can design some of that out. I think the public still jumps to the blame game of, well, which doctor screwed up, which nurse screwed up, looking for like singular fault. With the collision in DC, and we're recording this Monday, February 3rd, we don't have an NTSB report. We don't have good information on what went wrong. Even trying to put the political blame game aside, I still hear a lot of blame of like, well, which air traffic controller screwed up? Which pilot screwed up? And I'm like, the answer is probably not found down that path of a sole individual screwing up. Was there equipment failure?
But it makes us feel better, right?
No.
That's why we do it as humans. It makes us feel so much better to believe or know that it's just one person messed up. The system's fine. The system worked. Yeah. Works when it's being used right. If just one person did something wrong, then we can get rid of that person and I'll feel good again. And that's why blame and shame is still prevalent in all industries. It's why people jump to conspiracy theories, because they don't have the answers fast enough. And we require the answers within 2 hours of something happening. And it's like, there's usually a lot more at play in terms of how this got to a point where something that bad could happen, no matter what industry it's in. Yeah. And I think a lot about like, I get so frustrated when I rent a car and, every car, the core parts of them are the same. Steering wheels on the left side of the car, and the accelerators on your right foot and the brakes on your left. But the damn ignition is different in every car.
Right.
And so I when I get into a rental car, there's this like 4 seconds of frustration where I'm like, okay, am I pressing a button here? Am I pressing it here? Am I turning a knob? Like, how do I turn this car on?
Yeah.
And if you put that kind of a thing in the healthcare setting, that's bad. That becomes a real problem. And that's where, to sort of, I'm transitioning us a little bit here, but like that's where you get into this tech world and you've got all these people out there who are just so hungry to fix user interfaces, to fix problems that exist that people in those industries can't solve because they're working on too many things. And you need people who can see a problem and fix a problem. Yeah. And sometimes it's really just as simple as, well, look, that button needs to be in the same place for every single person who's going to use it. Yeah.
Well, if you figure out how to start the car, the next question is, how's the gear shifter work? Where is the gear shifter?
Yeah, now they're buttons. Sometimes they're...
The last time I rented a car, and the shifter was actually one of the stalks coming off the steering wheel on the right-hand side. And so I was able to figure that out. But the problem, and the thing I feared, is that the vehicles I normally drive, that's how you, if you pull forward on that right stalk, you clean your windshield. It sprays and it wipes. I was really afraid that I was going to try to, my brain would have been saying, I want to clear the windshield, and I would have thrown the car into neutral while being on the freeway.
Yeah. Now you see why, especially and we're going to keep coming back to healthcare, obviously. But you see why people are always clamoring, can we just make it the way it used to be? It was so easy back then. Yeah. But they forget that it was also probably pretty bad back then, too, for a lot of other reasons. Yeah. And so what's great about technology is that it can usher you into a new age of things happening faster and more reliable, but then you're also adding new problems every time. So it's like you're chasing a dog chasing its tail, but at the same time, and we bring this up in the new film, if the kids who are in medical school right now, they have lived their entire life online with phones in their pockets, access to everything all the time. they're not afraid of technology.
Mm-hmm.
They expect it. And if we're not building hospitals behind the scenes for that generation of clinician, then once they take over,
Mm-hmm.
it's going to be a problem. And I think we have to be able to recognize that we're in this very small window of time right now where we've got to get away from the old and into the new.
Mm-hmm.
And I think when you see a hospital that's doing that, it actually tends to work much more smoothly.
Yeah.
But it's a big leap for any hospital to take.
Yeah.
They just have to be willing to do it.
Yeah. Our guest again today, Mike Eisenberg, his new documentary is The Pitch, Patient Safety's Next Generation. It's available now. And I'm curious, from when you started, like your initial concept of the film, did it shift direction? I mean, there was a lot of focus on technology. He's an entrepreneur who's featured prominently, who's trying to help save lives and build a business that can commercialize approaches to that. Was that the initial vision, the focus on tech, or did it just evolve as you were learning about what's happening?
It was definitely the original idea of the movie to follow up to Air is Human with a focus on how technology is going to usher in a new age of patient safety.
Uh-huh.
That's the that's the movie we're going to make.
Yeah.
When I start making films, before I've rolled camera on anything, I write an outline of the movie I would like to see.
Uh-huh.
And how it would work perfectly, and in our perfect world, we were going to film competitions where we would see like multiple different groups or individuals vying for a first prize and tell the story of how people in that area, entrepreneurs and tech innovators, how they break into the healthcare industry. Because that's a very interesting question to ask. And we understand how big industry works, but we don't really understand how innovation works that much. And parallel to that, we were going to explore, and we do in the film, some examples of technology that's already working in the healthcare system to improve quality and patient safety. So, one of the first things I thought of was NASA control centers, command centers, and I went around looking to see if that existed in healthcare, and lo and behold, it does.
Yeah.
But it's not everywhere, right? It's only the hospitals that have that forward-thinking idea. They probably have some money that they can spend on it. It's not this $25 billion investment, although you can go big. The idea of it is really interesting. And of course, we ended up finding out that GE is, integrating their own command center software and systems and rooms into hospitals across the country. And we were able to go find one that was willing to let us in and show that. And I thought that was an awesome way to get people behind the scenes of a hospital to show how technology is making it run more smoothly. But that's big picture stuff. And so we also wanted to go and show some of the smaller examples in healthcare, like this one doctor in Michigan who's using virtual reality to replace anesthesia when it's not necessary, because there is risk when you're put under.
Yeah.
And I think it's just as important when you make a film like this to show people an example of something that's not obviously the only answer to a problem. So we kind of, right, like that's near the beginning, and we sort of take the trajectory upwards to command centers and big systems engineering. So but when we started the film, I think the hardest part was, how do we show the human story of it all? With the first film, it's very obvious. Find a patient or family story that's really compelling and interesting and can help people understand the humanity behind medical harm.
Yeah. The virtual reality.
Yeah.
I mean, the virtual reality story within the film was something I had never heard of and wouldn't have thought of, this idea of, alternatives. And to me, that seems like that, sometimes people say, oh, virtual reality is a technology chasing a problem. What is it a solution for? Well, you're right. Trying to reduce general anesthesia use, or, that is a significant issue worth addressing for a lot of reasons. So,
but when you look at technology in healthcare, especially, the technology, when you say the word technology,
Mhm.
right, to somebody, I think the first words they're going to think of are virtual reality, AI. And there are a dime a dozen uses of VR in healthcare right now, mostly around simulation training.
Right. Right.
So to see an example that was actually on a patient in an actual care setting was interesting
It was.
and unique. And you know, some of the people we talked to didn't like the idea of it. You know, we captured some interviews of people who were very critical of it. And we make the hard decision of, okay, well, if we put that in the movie, do we end up just sort of like taking one step forward, one step back, and not really helping people move forward in the story? So we just sort of showed people that it exists and allowed the doctor who does it to explain the pros and cons rather than having this debate on screen.
Yeah.
But, you know, that's the beauty of these movies, these documentaries, is when we screen them at a hospital or we screen them at a conference, or even just for students, there's always great debate afterwards of talking about the things that you see in the film and whether or not you believe in those ideas or you think that they do work. Or if you're in a hospital setting, how can we get why do we not have a command center? Or
right.
Something
Well,
like
I
that.
think there's this question of like belief versus evidence and data. And, you know, I mean, you can go back throughout modern medical history. You know, you read about, this question of why did it take 2 or 3 decades for hand hygiene and the acceptance that washing hands could prevent surgical infections. Like that, there were a lot of people who dismissed that idea, or they would have said, I don't believe in that. And, you know, eventually, you know, coming around. So, I mean, a naysayer could be onto something, or they're just kind of following in the history of medical naysayers. You know, anesthesia back in the day was supposedly adopted very quickly because that solved a important problem for the surgeon, meaning a patient screaming and moving around. But
at the same time, nowadays, anesthesia, especially the kind where you're actually put under, is oftentimes just a sort of status quo. Patients don't want to deal with the idea of the pain, and the surgeon would like a patient that's not going to squirm.
Right.
And most people will pay for that, and the hospital's built for that.
Mm-hmm.
So it's asking a lot to incorporate VR and outpatient surgery. And, you know, but this is a unique situation in the film. This is hand surgery. This is local anesthetic. This is a small potatoes version of it, but they're expanding their work into pregnancy even, you know, and they're going big. And I think that's, you know, we caught this at an early stage of its development. It's going to be something that people who, you know, are in their 20s right now and have grown up with VR being a cool gaming idea, they're going to probably want that in the future. Apple's certainly not shying away from trying to normalize VR headsets. And I don't see a future in which we're all walking around like idiots with headsets and nobody can see each other's eyes anymore or anything. But in healthcare, maybe there's something there. And it's interesting to just sort of look at it.
Yeah. And, you know, I think without giving spoilers away from the stories in the film, I mean, one thing that jumps out to me as a general discussion point is, you know, kind of using new technologies that maybe aren't equally affordable or available yet. You know, there was one story in the film I thought was fascinating about using a combination of DNA sequencing and machine learning algorithms to identify non-obvious outbreaks of infection in a hospital where the patients weren't all in the same unit. And, you know, this is question of like discovering these things in novel ways versus the things I would argue at a human level, at a process level, every hospital can do when it comes to proper hand hygiene or sterile procedures or wearing gloves. And some of these things come down to, I would call them systemic problems around training or communication that aren't really like they're not a shiny new technology problem. I'm not saying there's not. I mean, you know, the technology is helpful, but I would say yes, and like let's do the human level stuff too.
Well, what's fascinating is, and you've done a good job of following the sort of Hollywood rule of if you're going to talk about a movie, just talk about the first third of it. It's sort of like the 2 early examples, so we're still good. Not that this is a spoilery movie, but
sure.
But I appreciate it anyway. In that example in the film, Well, the story that was so shocking to us that, of course, made it into the film is this part of, one of the early examples of this tool that they incorporated where they're using machine learning to identify outbreaks early and using genetic tools to get to the core of what the issue is before it becomes an outbreak. One of the earliest examples, they discovered that these infections that were similar but were in different areas of the hospital were all related to something that was happening in the sort of the depths of the hospital where they were, putting together some testing. And it turned out that those people were using a piece of technology that was, created by a company and had a tutorial on how to use it. And in that tutorial, they weren't wearing gloves and they weren't washing their hands. And so these people just sort of like, horse blinders did what they saw.
Right.
And it's contrary to what we were saying earlier, which is fascinating because, earlier I was like, the technology is typically pretty consistent. It's the hospital's culture of safety that's usually the problem.
Mm-hmm.
These things are related, but, that's where you can't leave any stone unturned in a health system. There's so many moving parts.
Right.
And, they're going to follow the instructions. Why wouldn't they? But they should already have known. Like, that should be second nature to them. That just because some random, intern who made a video about how to use this tool at a company, that you shouldn't only do the things you see in that video. And I think this is probably a very unique example. This doesn't happen everywhere, but it happened. And it's a great example of how, these kinds of things can occur. And they're lucky that they caught it as early as they did, probably. Right. But at the same time, the modern tools are what allowed them to see that was what was happening.
Yeah.
So, man, this is the Swiss cheese model in a nutshell. But what we got to do is we've got to find ways to use the tools that other industries have been using for a while, start applying them in healthcare. But what those two examples you gave do is they show you how somebody in healthcare who's experiencing a problem identifies that problem and partners with people in technology to solve it. Mm-hmm. Right? One's a hand surgeon who's like, I just don't want my patients always having to go under when they don't have to. And then he partners with a VR company. And he's the CMO now. And then the other one is this guy runs a lab in Pittsburgh, and he's trying to identify outbreaks in the hospital. And he realizes that he could partner with somebody over at Carnegie Mellon who specializes in AI machine learning models to help create a computerized system so that it's not just all human math to try to figure it out because it takes too long.
Yeah.
So again, that's the key. I think that's what we discovered in making this film.
Yeah.
If you really want to change healthcare, there's two ways of doing it. Either you're an innovator and you go look for a problem and you solve it, or you partner with healthcare professionals to solve it. Mm-hmm. Or you're a healthcare professional, you have a problem, you partner with somebody in technology to solve it. That's literally A plus B or B plus A. It's the same thing. But, it's about recognizing when something can be solved by a piece of technology and making sure the right people get in the door and start solving it.
Yeah. That's well said, Mike. Again, we've been joined today, Mike Eisenberg. The new film is The Pitch, Patient Safety's Next Generation. It'll be in the show notes, but for people who are listening or watching, what are the best ways to go and stream and watch the film? I'll maybe ask for one as an individual. Secondly, if you're an organization, are there different ways to go about it?
Anybody can watch it now by renting it on Apple TV or Prime Video, and a few of the other. If you use like some of the less popular brands of streaming, hopefully eventually it will be subscription based. Well, no, not hopefully. It will become subscription based, so you won't have to spend money up front to rent it if you already have subscription modeling. And then eventually, I'm sure we'll get into the educational space where if you have a library card or you're familiar with Canopy, you can watch it for free on Canopy. That's down the road. Mm-hmm. We just released in September, and the initial release was fantastic. But really, what we understood from the first film is the power of a documentary like this is showing it to hospitals. universities, conferences, getting it in front of the key decision makers, and the people who can ask the key decision makers why they're not doing something. And so we've had great success in booking the film at, coast to coast. I'd love it to continue doing that as long as possible. I'm going to be at a conference next month. I was at a conference last month. Like, this is what we want out of this. We want to bring it to the best places with the most people. People can, if you run one of those conferences, or you're at a university and you think this film would be beneficial, there's a booking page on our website that anybody can connect with me, and then we can just talk about how to best screen it at your hospital or organization. So our film's website, which also has streaming platforms you can click, everything's there, is www.thepitchdocumentary.com. And again, it'll probably be in the show notes and you can click that. But right now, the best thing we can do is get people aware of this film, and I love having the chance to talk about the topics inside of it and around it with people like you, who I know are working so hard on this, and people in healthcare from top to bottom need to be talking about these issues. They need to be talking about how can we incorporate technology to make our care safer. And I just don't think they're doing it unless they're instigated.
Well, thank you for what you're doing to instigate discussions and inspire action and change. And again, I hope people will check out the film. Very interesting. Highly recommended. Again, it's The Pitch, Patient Safety's Next Generation. Mike's previous film, again, we discussed that in podcast episode 329. That documentary was called To Err Is Human. So maybe do a double bill, check them both out. But Mike, congratulations on the release of the film. And it was great to have you back here on the podcast again.
Thanks, Mark. I appreciate it.
Thanks.